Hello everyone, my name is Kyori Kim, and I'm one of the social media section editors of the Archives of Plastic Surgery. I'm excited to introduce Hot of the Press. Twice a month, we'll be hosting Hot of the Press with one of the authors of latest APS paper and two panelists. It offers you a special opportunity to directly hear from the authors and join an insightful discussion between panelists. You can also leave your thoughts as a comment for further discussion.
Hi everyone, welcome to Archives Plastic Surgery, Hot of the Press, the May issue. Today we'll be discussing the paper written by Dr. Joseph Escandón and Dr. Oscar Manrique from University of Rochester Medical Center. The paper we'll be discussing is Reconstruction of Pharyngolaryngeal Defects with the Iliocolon free flap, a comprehensive review and how to optimize outcomes. All right, so Dr. Escandón, without further ado, it would be great if you could share your presentation with us.
Hi, my name is Joseph. I'm a postdoctoral research fellow at the University of Rochester Medical Center, and I will be presenting our paper on the reconstruction of pharyngolaryngeal defects with the Ileocolon free flap, a comprehensive review, and how to optimize outcomes. We have no disclosures. So head and neck cancers are the sixth most common type of malignancies worldwide with a high mortality rate. Local and regional recurrence rates have been reported similar with radiotherapy in comparison to surgical resection. Therefore, radiation has become the standard of care for early stage hypopharyngeal and laryngeal cancer. In advanced stage disease, nonetheless, free margin surgical resections are required and free tissue transfer becomes necessary. Different speech rehabilitation techniques have been reported following pharyngolaryngectomy, including esophageal speech, the use of electrolarynx, or a tracheoesophageal puncture with voice prosthesis insertion after primary closure or reconstruction with jejunal free flaps or fascicutaneous flaps. Some of the disadvantages of these methods include a high incidence of leakage at the anastomosis sites or at the TEP sites. In this setting, the only flap that provides a natural voice tube with an unidirectional valve that assists in the passage of air from the trachea to the pharynx and prevents regurgitation of food or saliva into the airway with the self-cleansing capacity is the Iliocolon free flap. Therefore, we performed a systematic review of the current evidence on the use of the Iliocolon free flap for reconstruction of defects following pharyngolaryngectomy, and we provided several technical considerations to optimize the surgical and clinical outcomes. We performed a systematic search across different indexes, and we included patient-based studies fulfilling the selection criteria shown in this table. Different flap configurations were reported, like the standard isoperistaltic Iliocolon free flap, initially described by Kawahara and colleagues, for definition shunt and to improve valve continence, while a 28 French tube was inserted through the ileum. The anterior and posterior aspects of the cecum were wrapped around the terminal ileum and sutured as a cecal plication. The antiperistaltic Iliocolon free flap was versatile due to the wide diameter of the ascending colon for patients who underwent an extensive pharyngolaryngectomy with resection of the rhinopharyngeal mucosa, soft palate, and the tonsillar foci. Remarkably, Sartorius et al. Strengthened the ileocecal valve continence by performing a single or double row of lumbar sutures along the ileal tract instead of performing the cecal plication described by Kawahara et al. Then we have the detubularized Iliocolon free flap, which was resourceful when the posterior pharynx was spared during anterior pharyngolaryngectomies. We have the Iliocolon patch flap reported by Kabayashi, which was practical in patients who have undergone only a laryngectomy. And the reverse Iliocolon free funnel flap, which avoided potential size mismatch at the proximal and distal ends of high pharyngeal and low esophageal defects, respectively. Now we have the Chemeric Seromuscular Iliocolon free flap, which was specifically designed to prevent leakage around the distal anastomosis. For this flap, an additional segment of the ileal loop was isolated from the border of the ileum and was sutured with interrupted absorbable sutures to the anterolateral walls of the cosophageal anastomosis, providing a double wall or double layer closure. Also, to achieve a better ileocecal valve continence, Rampazzo et al. Redefined the method that is used nowadays, which includes an external plication with subserosal sutures between the ileum and the cecum to decrease the ileocecal angle to 30 degrees, and an internal plication of the ileocecal valve with interrupted absorbable sutures to achieve a 0.5 centimeters valve aperture, as seen in the image. Overall, 21 studies were included. The male to female ratio was 8:1. The average age was 54.6 years, and the mean follow-up was 24.7 months. The most common indications were for reconstruction were hypopharyngeal and laryngeal carcinoma, thyroid carcinoma, and esophageal cancer. Most patients included in most studies were reconstructed for defects after resection of a stage 3 and stage 4 cancer. Primary reconstruction was reported in 24.6% of patients, and secondary reconstructions were performed in 19.1% of patients. The surgical time ranged from 8 to 14.5 hours, and hospital stay was 23.09 months, days on average. Postoperative chemotherapy and radiotherapy was reported in 15 studies as part of adjuvant radiotherapy. Lab success rate was ranged between 91 and 100%. Some series specifically detailed the reason for failure in some patients, and partial flap loss was reported in 2 articles, which was 5.88%. The revision rate for the microanastomosis or due to bleeding or hematoma ranged from 0 to 16%. Postoperative leakage was reported between 0 and 13.3% of patients, most of them occurring at the colosophageal junction. Reintervention directed to close leakage was reported in 8 studies, and these interventions were local skin flaps, regional flaps, or additional chemeric seromuscular Iliocolon free flap. The rate of a structure ranged from 0 to 10%, and procedures to address the stricture with additional flaps were reported in 2 studies. The most common donor site complications was self-limited diarrhea, erosive gastritis, surgical site infection or surgical site dehiscence, ileus, and eventration was reported in 1 patient. However, it was highlighted that the patient had violent coughing. Before Ciudad et al. Published the results in which optimal functional outcomes were attained using an ileal segment of 7 to 15 centimeters, the percentage of patients required additional procedures to treat redundancy of the ileal conduit ranged from 0 to 35%. Afterwards, the rate decreased to 7.3%. The revision procedures to strengthen the ileocecal valve competence range from 0 to 8.5%. In terms of patient-reported outcomes using the tool Quality of Life C30, a score of 55.9 was reported for the global quality of life and regional health, and the average score for the 5 functional subscales ranged from 59.8 to 83.3, which suggested an overall average to good postoperative functionality. When compared to the pneumatic artificial larynx, PAL, the Iliocolon free flap yielded better outcomes regarding self-esteem and lower severity of affected speech intelligibility and fluency. In recent series using a 7-point Likert scale to evaluate deglutition after reconstruction, most patients reported a score of 5 or more, with a median score of 5, and also, as previously indicated, an ileum length between 7 to 15 centimeters provided better outcomes. Overall, the phonation time with the Iliocolon free flap was 10.25 seconds. The average frequency was 120 hertz, and the mean dynamic range was 59. Using a 5-point Likert scale, in recent studies, the good results were reported in 64% of patients regarding phonation, while moderate and substandard results were reported in 21% and 6% of patients, respectively. Finally, using a simplified Likert scale, optimal outcomes for loudness, intelligibility, and fluency were obtained with ileum segments of 7 to 15 centimeters. In conclusion, the different designs of the Ileocolon free flap provide a versatile and reliable alternative for reconstruction of middle-sized defects involving the hypopharynx, larynx, and proximal esophagus. Its three-dimensional configuration and functional anatomy encourages early speech and deglutition, which in turn allows for early adjuvant therapy with an optimal time frame, coupled with minimal donor side morbidity. I want to thank to all of the authors who participated in this study and to the mentors who provided the best input for this great result. And I want to thank you, the Archives of Plastic Surgery, for giving us the opportunity to publish this study. Thank you very much.
All right, thank you, Dr. Escandón, and congratulations to both of Dr. Escandón and Dr. Manrique for a great study. And then today we're joined by Dr. Kyori Kim from Gangdong Sacred Heart Hospital as a panelist. So first we'll start the discussion from a question from Dr. Kyori Kim.
First of all, thank you so much for sharing great work. I think this paper shows well this option can be a reliable procedure for the pharyngolaryngeal reconstruction. So my question is, I think because ischemic time is such a critical point for the intestinal flap, I want to ask, do you guys have any strategies to reduce the ischemic time with this procedure?
So there are a couple of strategies that can be incorporated during the surgical management of these patients. First of all, the communication with a general surgeon is important. One of the, as is obvious, one of the disadvantages of this flap is that it involves harvesting a flap from the intra-abdominal region, right? So perfect communication with the general surgeon or the other surgical team involved with the flap harvest is a must for this flap. In fact, there are some studies that have shown that ischemia beyond the 30 minutes for intestinal flaps causes damage to the basal lamina of these cells and to the parenchyma and of this flap. So an optimal communication with the surgical team harvesting the flap is a good option. And then another important remark that I should mention is we are presenting outcomes of reconstruction of head and neck, right? Most of these patients have vessel depleted necks. Finding recipient vessels is complicated. So before you even transect the flap, you need to be sure to have your recipient vessels dissected and ready for the anastomosis. I think those strategies are kind of a good advice for anyone trying to reconstruct any structure of head and neck with this flap.
So Dr. Kim, thank you so much for your question. And first of all, Dr. Escandón, congratulations. It was a really well done paper, very well executed, and it was a great presentation. So one more specific towards the ischemia time. One of the main things is in Taiwan, we used to dissect these flaps on our own. In some facilities, they get general surgeons involved, but there's some people that, especially with one of the authors, Professor Chen, we used to dissect those flaps on our own. So I think that brings a little bit of a couple of advantages. One, looking at reliable vessels, making sure that the vessels don't get damaged, especially for the flap. As you mentioned, not only the bow flaps, but are one of the most sensitive flaps in terms of ischemia time. So having the recipient vessels ready to go, that is one strategy. Two, if eventually you can help the general surgeon or yourself to help have the flap ready to disconnect at the time before the transfer, that's another important point. And in some occasions we use ice. And so we place the ice at the level of the neck where we're gonna place our flap while we do the microanastomosis. As you know, lowering the temperature technically decrease the metabolism of these flaps, so that can help a little bit with the ischemia time. And another thing that we find out is that prior to doing the resection of these flaps, bowel preparation, it's important so that you decrease the bacterial load that can eventually also cause some issues during the transfer and during the ischemia time. So I think that those are important factors to consider.
So I have a question. In your experience, like, is this your primary go-to for a pharyngolaryngeal defect reconstruction, or like, is this a secondary choice after you do vascular cutaneous or jejunum? And if there are any contraindications for performing this procedure, for example, if you do ever do colonoscopy, or if for any concerns or anything like that.
Thank you for your question. So initially, as this valve has the ability to restore function and form, what we think is that this flap may be a good alternative for young patients with long life expectancy. As you know, we're covering the same function, which is deglutition and restoring the digestive tract, and the function, which is producing inflammation in these patients, which will have a long life expectancy and will be able to, maximize the use of this complex procedure. I think this flap must be regarded as an optimal alternative, and also depending on the experience of the surgeon. But of course, in some patients, you would consider, like in patients who had previous infectious complex abdominal processes, like abdominal abscesses, who required any type of procedure in the bowel. I don't think this is a good option, and you will need to take into consideration that flaps, that the ALT, the radial forearm free flap, are a good option with low morbidity. I don't know if Dr. Manrique has more to add.
Yeah, thank you so much, Dr. Cho. That was a great question. So I think a couple of things. One, depending on the size of the defect, I think that, and the background of the patient, I think Dr. Escandón brought a great point in the first question. Depending on the vessels, if we have necks or depleted vessels, if patients had multiple operations in the past, how many flaps have failed, because as you know, a lot of these patients have, unfortunately, a lot of comorbidities. This is a region in which the functionality and the type of tissues that have to be reconstructed, it's complex. So I think that analyzing, as I said, how big the defect was, what other complications there were before, and more important, how the surgeon feels comfortable offering these flaps. In some parts of the world, I know that there's great microsurgeons and reconstructive plastic surgeons that work significantly amount of times in the head and neck region, but they have never performed these flaps. And so it's not that I would say that one flap is better than the other, but I think that the comfort level of the surgeon, it's very important, because you cannot go, especially as Dr. Kim asked in the previous question about ischemia time, going on your own and dissecting the colon or this part of the ileum, plication of the cecal valve, and all these other things that if you don't have the experience doing that, I would probably not suggest having this as the first choice. But if you feel very comfortable, if you have good experience, as the data that Dr. Escandón provided with a success rate above a 90%, I think it's a good choice. I think it's always discussing with the patient all the pros and cons of each procedure. As we always tell our patients, there's no surgery that is perfect, painless, scarless. There's always going to be some risk factors. Someone who had multiple laparotomies in the past, bowel resections, I mean, those are patients that you're not going to offer this type of flap. So I think that it's the BMI, the body mass index, also brings a lot of into consideration. So it's multifactorial. But as Dr. Escandón concluded, I think it's a good choice. And if you feel the comfort level and you analyze all the other risk factors, then I think it's a good flap.
If I may add, it is important, like in the presentation, we highlighted that this flap has several types of configurations, like the funnel flap, the Iliocolon free flap, as a patch flap. So it is very interesting how you can use this flap and you can tailor this flap to the requirements of the defect in the patient. For example, if patients has only, if the patient had an laryngectomy, you can use the patch flap, and it will provide an outstanding option for only voice restoration. In the cases of patients that have a massive resection of the rhinopharyngeal mucosa and low defects of the esophagus, a funnel flap is a good alternative. Of course, something that also must be highlighted is that when you do a funnel Ileocolon free flap, you lose the valve because the ileum will be anastomosed to the distal side of the esophagus. So in these cases, you will still require any type of voice restoration technique like TEP and voice prosthesis insertion. But yeah, the where I'm going is you can tailor the flap to the requirements of the patient. That's something very important of this flap.
And I have a question on the technique aspect of it. So, you mentioned that there's an ideal length for the, the reconstruction. So what are your tips and tricks on finding ideal lengths so you do prevent like fistulas or, any others? So if it's, let's say the defect is 10 centimeter, then how do you determine like what will be the ideal length that you will need to harvest? And then also, is there any maneuvers that you use to prevent an fistulization?
Thank you, Dr. Cho, for the question. So this range of 7 to 15 centimeters, as you highlighted, is kind of a green zone. But still this is a spectrum of 8 centimeters that you can choose the length of the ileum for patients. So ideally, this length for the ileum is what it has shown in literature to provide the best outcomes. However, it must be also highlighted that not all the patients have the same size. So it is important to take into consideration that depending on the size of the patient and depending on the size of the airway, depending on the size of the resection, and also depending on if when you insert the flap there is kinking, you can tailor this approach. For instance, in some cases, you may be worried about the size, about kinking the pedicle if you have a long ileum segment. In these cases, sometimes you can do just restoring the aerodigestive tract, doing the anastomosis with the flap to the hypopharynx and to the esophagus without doing the anastomosis for the ileum and the trachea. And just leave it like that, wait, and do a delayed anastomosis for the ileum to the trachea so you don't kink the pedicle. That's a good option. Also, as we mentioned, there is this modification, which I think it's genius, the seromuscular Chemeric Iliocolon free flap, taking a seromuscular segment of the ileum and just reinforcing the anterior wall of the coloesophageal junction. I know for sure that in previous reports from Professor Hanchi Chen, he has highlighted the lower recurrence of leakage at this anastomosis site with the use of this technique. I don't know if Dr. Manrique would like to add further information.
Yeah, thank you. I think it was very complete. I think also now with advances in technology such as ICG angiography, we're able to assess also the viability of some of these zones for the flap, especially at the anastomosis site. Because one of the main concerns that we have with these flaps is that even though your microanastomosis can be intact, they can have good flow, good venous return, we don't know if the resections that we do at the level of the bowel are still going to be perfused based on the perforators or the pedicle that we have chosen. I think the anatomy is very reliable, but I think that lately and in the last several years, using this type of technology has definitely helped reducing some of these complications, such as fistulas or edges of the bowel that can become necrotic, especially when we start doing the just a closure of the between the aerodigestive tract and the flap in order to ischemia and potential necrosis. So I think these are kind of like the main factors. And again, it goes back to the experience of the surgeon. Going back into how many flaps have you done? How do you see when you're a sick bowel? It's been in a couple of occasions while we were doing these flaps that even before disconnecting it, it starts getting congested, even in the abdomen. And so in those particular cases, it's sad to say, but it only goes back to experience who know you have to supercharge it, which is another topic that is not part of the paper, but has been shown to decrease the level of congestion of some of these flaps using extra vessels in the neck. So, but I think overall it's a very reliable anatomy, and supercharging these flaps or use of imaging studies such as the ICG angiography definitely have helped.
Sounds good. I do have one more question, but Cody, do you have any other questions? I don't want to take all the time.
Okay, so I want to ask question like from the general surgeon's perspective, like harvesting jejunal flap or the between jejunal flap and the ileocolon flap, what is the which option they feel more comfortable?
I think that is a very good question, because again, I think part of the selection of some flaps are in fact rely on the experience of surgeons, right? So one of the things with the ileocolon flap is that the vessel is, I would not say 100%, but more than 99% the ileocolic vessels. So the pedicle selection is pretty straightforward. But again, I think most of the decision on how you feel comfortable with each type of flap would be the experience of the general surgeon, or in fact, some plastic surgeons, as Dr. Manrique mentioned, harvest their own intra-abdominal flaps. So I think that part would be more related to the confidence of the surgeon elevating the flap. And of course, as Dr. Manrique mentioned previously, there are several technologies that aid in the decision of selecting which perforators or which pedicles are the best for the flap, like ICG, like real-time ICG during the flap harvest.
Yeah, and I think that even if you have a general surgeon or someone with some expertise dissecting these flaps, probably for us, and I have to say I'm a little bit biased because, again, back when we were in Taiwan with Professor Hunchi Chen, all these dissections were done by ourselves. So probably for someone that might rely on the experience of another surgeon, it's very important that you're present during this dissection, because you cannot leave someone who, even though they know how to resect bowel, because that's not the point of this flap, but know that they dissected and resected accordingly, preserving the vessels, respectful of the anatomy. So I would suggest that as a reconstructive plastic surgeon, you're present during the dissection and you guide the other surgeon if needed at the time of clamping the vessels, because again, any little mistake, it's just very detrimental for the flap.
So large bowel, the colon known to be more resistant to the ischemic and reperfusion tissue damage. Do you think it affects in this procedure?
I think that yes, depending on the length of the bowel flap, we have even done studies in animal models in which we take part of that iliocolon flap in small bowel, and we started ligating the arcades of the mesentery for these bowels little by little, just to show how long can some of these conduits resist against ischemia time. But in reality, I don't think that there's a significant difference, at the time if you're doing the resection and unfortunately everything's connected and blocked as like a chimeric flap. You want to be careful that you don't expose these flaps to prolonged ischemia time. We even reported a study of another iliocolon flap that was done probably 15 years prior to the presentation of this patient to the emergency room, in which you would believe at that time the flap should be neovascularized if you would clamp the pedicle, but it was not. And I think the serosa also has a lot of deal with the layers of the flap in terms of helping integrate into the body and around it. So yes, definitely there's differences between one bowel and the other, but I would be very cautious about thinking that one conduit could be more resistant to ischemia. I will treat it as complete, flap that if any case there's any ischemia or anything, it's going to be for the detriment of the entire flap.
So actually, I'm using sigmoid colon for vaginoplasty for the gender affirming surgery. So theoretically, we are thinking maybe there's a chance of colon cancer in long termly. So what do you think about it? Or do you have any follow-up schedule for that?
Yeah, absolutely. I think that's another great question. There's even studies that have been reported from Turkey in which a lot of these sigmoids, they put them under a little bit of ischemia time. Again, most of these vaginoplasties with the colon are pedicle flaps. So technically, you don't have to perform a free flap for these type of reconstructions, but still, I would say that more concern about that is risk of pouchitis, yes, risk of colon cancer in the future, congestion, potentially inflammation, damage to the bowel flap. But yes, of course, I mean, you're basically transferring a tissue that could be susceptible for any type of disease, not only cancer, but diverticulitis or other type of inflammation. So yeah, that's something that it's important to discuss with the patient prior to doing this. But for the vaginal reconstruction, I think we even had the opportunity to publish that long time ago in terms of functional results are very good. But yes, those are risk factors that you have to explain to the patient prior to moving forward with surgery.
Thank you.
All right, I promise this will be the last question. And I think, so the question I have is, what's your postoperative flap monitoring protocol? Do you ever place implantable Doppler? And then also, what would be your postoperative protocol? Meaning, when do you start, how long do you wait before you start diet? And then when do you place the speech function? And then if patients radiate or non-radiated, is there a difference between your approach?
That's a great question. So in terms of monitoring, it depends on your comfort level and the technology that you have at the hospital. Again, in some occasions, we left the neck open and just skin grafted the jejunum or part of the colon. So we can not only see the flap physically with peristalsis, which is one of the main indicators of that the bowel has survived, but also using external Dopplers, putting it close to where the pedicle is or where the bowel is, because you could even feel in some occasions the signals on the opposite side where the pedicle is, which is very reassuring. So a lot of times in the beginning, we just cover it temporarily with a skin graft to monitor the flap in these two cases. If you have the technology and the resources, implantable Cook Dopplers are also great. As you know, like any type of even lack of signal, or even if it's working, it's mandatory to go back and take these patients immediately to the operating room. In some occasions, you just bury the flap completely. So both, I think that are very good options. Again, depends on your level of trust, how much you have, the technology that you have in the hospital. And in terms of the deglution and everything, and when to start diet or the voice therapy, we start with barium swallows or gastrografin more exactly, in which before you start any type of diet, you want to make sure that there's no leaks. Because again, imagine you just letting the patient go ahead and eat and there's a leak or a breakdown. Of course, I mean, that's would be a big no-no. So a lot of times gastrografin, it's a good material that we use with radiology to prove that there's no leaks. And beyond that, we like to start a very slow initiation of diet, especially soft liquid diet, something that is not too harsh for the patient, and little by little advance these protocols. It's always good to work with a therapist as well in terms of the deglution, phonation, and depending on how the patient's feeling, the other comorbidities. Voice therapy usually is also encouraged to be started really early. As Dr. Escandón mentioned, I think that's one of the main benefits from this flap, that you have the availability to, with the own valve and with the ileocecal valve and the plication of this valve, to eventually produce sound. But yeah, it can vary also depending on the how much the patient goes for further follow-up, if they follow all the instructions, if they go to their therapist. So I think these are very important questions.
So as Dr. Manrique mentioned, there is a very important protocol for this, for the post-op of this patient, in which it depends on the complications, because if there is leakage, starting oral diet, oral intake would be a problem. So initially, this patient should have rehab with oral intake. Once the patient has completed or is available to have regular diet, or at least clear liquids, you should work with a physical therapist and occupational therapist to start phonation approximately 3 months to 1 year after surgery. And it is important to highlight that these patients are able to have a very quick rehabilitation, as the only thing that they would need would be their thumb for obstruction of the tracheostoma and to start using the valve. Or there's another option, which are pressure valves that the patients can put in the tracheostoma and help initiate phonation.
All right, sounds good. I would like to thank you again, Dr. Manrique and Dr. Escandón, for a great presentation and discussion and paper, and also Dr. Kim for joining a fantastic discussion. Thank you, everyone, for listening for Archived Plastic Surgery, Hot of the Press May issue, and we would like to see you again for the next issue. Thank you.
Thank you very much for joining this fantastic discussion. Be sure to tune in for other articles we'll be discussing on future Hot of the Press. You can also connect to the Global Plastic Surgery Society through our YouTube channel, Facebook, Instagram, and Twitter. We are looking forward to meeting you on our APS social media. Let's be social.